All right, we'll get started. And today it's a beautiful fall day. This is the week of the NIH Research Festival. So our first speaker today is Kieran Dunleavy, and he obtained his medical degree at the University College of Dublin, the medical school. Subsequently came to NCI doing a medical oncology fellowship. He's now the clinical director of the lymphoid malignancies branch. The title of his talk, Precision Treatment of Diffuse Large B-Cell Lymphoma. Kieran.
Okay, thanks for the nice introduction. I work in at the National Cancer Institute in the lymphoid malignancies branch, and my research focus is in the biology and treatment of lymphoma, and we develop new treatments for different types of lymphomas, and with a particular focus on novel agents and diffuse large B-cell lymphoma. So over the next 45 minutes, I'm going to talk about some of the work that we do. And at the end, if you have any questions, I'm very happy to answer them. So just to put lymphoma, non-Hodgkin lymphoma, into some kind of epidemiological perspective, there are approximately 60,000 new cases of non-Hodgkin lymphoma in the United States every year. And as you can see from this slide, the incidence of non-Hodgkin lymphoma has been The incidence of non-Hodgkin lymphoma has been steadily increasing over the past 20 years in males, but not in females. And there are several reasons for this, one being that HIV is associated with an increased risk of non-Hodgkin lymphoma, particularly two types, diffuse large B-cell lymphoma and Burkitt lymphoma. And HIV is much more common in males than females in the US. But the good news is that the death rate from non-Hodgkin lymphoma has been decreasing in both males and females. And if you look at the breakdown of non-Hodgkin lymphoma, about 40 to 45% of non-Hodgkin lymphomas are diffuse large B-cell lymphomas. The second most common type is follicular lymphoma. And then there are a number of different lymphomas, mantle cell lymphoma, small lymphocytic lymphoma, T-cell lymphomas. In this part of the world, about 85% of non-Hodgkin lymphoma are B-cell lymphomas. And we're particularly interested in this most common type of lymphoma, diffuse large B-cell lymphoma, and that is curable in a high proportion of cases. So over the past 30 years, the most significant advance in this field has been the addition of a drug called rituximab to CHOP chemotherapy. So I'm not sure how familiar you are with this, but the standard treatment for this lymphoma since the 1970s has been a chemotherapy regimen called CHOP. C stands for cyclophosphamide, H is hydroxydonorubicin or doxorubicin, O is oncovine or vincristine, and P is prednisone. And since the 1970s, people have been using this regimen, and about 15 years ago, the French did a study where they added a monoclonal antibody called rituximab against CD20 to CHOP. And they did a study in people over the age of 60, and they showed, as you can see here, that there was a significant survival advantage when they added rituximab to CHOP. So these are the results of that study at approximately 10 years follow-up. So this is the standard treatment for patients with this disease. They get the monoclonal antibody, rituximab, with CHOP chemotherapy. But if you look at patients of all ages with diffuse large B-cell lymphoma, as you can see from these curves, there remains a significant proportion of patients for whom standard treatment is inadequate. So And we divide our patients into different risk groups based on clinical characteristics that they have when they present. But as you can see here, for patients who have intermediate risk or high-risk disease, the cure rates are pretty low. So there's a lot of room for improvement. And this is really what we focus our program on, trying to better understand why this is so. And I'll explain this over the next 40 minutes or so. This just reiterates what I've said already. If you go back to the 1970s, CHOP was the standard treatment. There have been various attempts to improve upon CHOP, but really at the end of the day, the only one that has been significant has been the addition of rituximab. This is a summary of some of the major studies that have been done over the last 30 years, but there were lots of really good ideas, but they didn't improve upon the results of using CHOP as the chemotherapy backbone for this type of lymphoma. So in our field, we, as I said, have tried to improve upon these results and really did various things to do that. One thing that people have done is giving more cycles of treatment. So we usually give 6 cycles of treatment, and they've investigated whether giving 8 is better than 6, but the answer is that it didn't help. People have tried giving the R-CHOP more frequently than every 21 days. So 2 big trials, one in the UK and one in France, looked at giving the R-CHOP every 14 days and compared that in a randomized study to giving it every 21 days. And both of those trials were negative. So they showed that giving it over a shorter period of time was not associated with a better survival and actually was associated with more toxicity. So most investigators in the field have abandoned studying this for that reason. What about bone marrow transplantation? That's something that can be very useful in hematological malignancies, in leukemias and lymphomas, and in patients who have a very good response at initial treatment. That has been tried in the upfront setting, but it's not been shown to be of any advantage, and it's associated with a lot of toxicity. What about superior chemotherapy platforms to the R-CHOP? Well, the French, the same group who showed that adding rituximab to CHOP was associated with a survival advantage. They developed another regimen called ACVBP-R, and they did a study a few years ago in younger patients, patients under 60, who had very good risk factors, and they showed that this treatment was better than R-CHOP in this group. But most people with diffuse large B-cell lymphoma are in their 60s and 70s, so they really would not be able to tolerate this treatment. So although it's an advance to show that it's better in a select group of younger patients, for the majority of people with this disease, it's not really a good option. We've been studying the dose-adjusted EPOCH-R regimen at NCI. We've done lots of studies using that, and we recently completed a study where we compared it to R-CHOP in a randomized study around the US where we accrued 550 patients. And we were able to obtain biopsies on most of the patients and perform gene expression profiling, and I'll explain why this is important over the next few slides. But I think there's no doubt that we need to incorporate novel agents into upfront therapy, and this is being investigated as well. So one of the most important advances in our field over the last 20 years has been the breakdown of diffuse large B-cell lymphoma into different diseases. So 20 years ago, pathologists understood this to be just one disease entity. This was work that was led by Lou Staudt at NCI and a group called the Lymphoma and Leukemia Molecular Profiling Project. And they applied a technology called gene expression profiling to diffuse large B-cell lymphoma. So they looked at the differential expression of tens of thousands of genes, and when they did this, they were able to divide diffuse large B-cell lymphoma into 3 different subtypes. One subtype was called the activated B-cell subtype, or ABC. One was called germinal center B-cell subtype, or GCB. And one was called primary mediastinal B-cell lymphoma, or PMBL. And all 3 of these subtypes originate from different stages of B-cell differentiation. So the ABC subtype comes from an activated B-cell, the germinal center subtype from a germinal center cell, and primary mediastinal lymphoma comes from a thymic B-cell. which arises in our thymic gland in the chest. And it's important, this distinction is important on a lot of levels. There are certain pathways that are important in the ABC type or in the GCB type or in the PMBL type. So this distinction into 3 different subtypes has really allowed us to think about what targets we want to go after and what makes sense in terms of developing new treatments for each of these 3 types. And the distinction into the 3 different types is important clinically because it's now clear from several studies that patients who have the ABC subtype have a much worse outcome. This is a comparison of the GCB and the ABC outcome. These are patients who received R-CHOP, and this is their probability of survival. And you can see in orange that patients who have the GCB subtype have got a much better outcome than patients who have the ABC subtype. So a lot of the focus of my work at NCI has been trying to understand the ABC subtype better and developing new treatments for it with my colleagues, Wyndham Wilson and Lou Stout. So for this talk, I'm just going to focus on work that we have been doing in the ABC subtype, first of all. Then I'll talk a little bit about targeting MYC and BCL2 overexpressing large cell lymphomas, because that's something that there's a lot of debate about in our field. And then finally, I'll talk about targeting primary mediastinal B-cell lymphoma, which is a type of diffuse large B-cell lymphoma that occurs in young women, usually in their 20s and 30s, and it's very closely related to another type of lymphoma called nodular sclerosing Hodgkin lymphoma. And we've done a lot of work in that subtype, so I'll finish the talk by talking about that at the end. So when you see the ABC, GCB subtypes, almost all children and young people who get diffuse large B-cell lymphoma have got the GCB subtype. It's very rare to see the ABC subtype in those people. But as patients get older, they have a higher risk of developing the ABC subtype. And you've probably heard about, or you're probably familiar with NF-kappa B because it's a very important pathway in multiple cancers. But one thing about the ABC subtype is that there's constitutive activation of the NF-kappa B pathway. Shown here are a number of NF-kappa B target genes, and you can see that they're highly expressed in the ABC subtype, but lowly expressed in the GCB subtype. So approximately 10 years ago, we did a study at the NCI. We set out to specifically target the ABC subtype and work in the lab looking at the GCB cell lines and ABC cell lines showed that ABC cell lines were very sensitive to an NF-kappa B inhibitor called I-kappa B kinase. But this was not commercially available. But there was a drug called bortezomib, which is a broad proteasome inhibitor, which was available at the time. So we constructed a study, the hypothesis being that if we added bortezomib to chemotherapy, we would selectively benefit patients who had the ABC subtype. So we accrued patients with relapsed or refractory large cell lymphoma of both the ABC and the GCB subtype onto our study. We did gene expression profiling to determine which subtype they had. They were treated with bortezomib, which targets NF-kappa B, and chemotherapy. And then we looked at the results of this group of patients. We treated approximately 50 patients. And what we saw was that patients with the ABC subtype did much better than patients with the GCB subtype, both in terms of their response, which I haven't shown you here, and their overall survival after the treatment. These survival curves probably don't look very good to you, but you have to keep in mind that most of the patients on our study were very heavily pretreated. They had had a median number of regimens, or the median number was 4, and a lot of them had had a bone marrow transplant before they came to us, so they were very refractory people. But this was an interesting signal that we saw that adding bortezomib was much more effective in the ABC subtype than in the GCB subtype. And about the same time that we did our study, another group at Cornell, they added bortezomib to chemotherapy and rituximab in newly diagnosed patients. And they didn't do gene expression profiling, but they used what are called immunohistochemical algorithms to predict whether patients had ABC or GCB. And when they did that, they also found, interestingly, that the GCB and ABC patients had a similar outcome. And you would expect that the ABC patients would do much worse, as I showed you in the curve before. So both of these studies suggested that you could preferentially target the ABC subtype. So since the time that we did our study, we understand mechanisms of NF-kappa B activation a lot better. And one thing that is or has been shown to be very important is B-cell receptor signaling. And there are different mechanisms of B-cell receptor signaling in cells. There's tonic B-cell receptor signaling, and then there's active B-cell receptor signaling. Active B-cell receptor signaling is shown here, and that is felt to be antigen-driven compared to tonic B-cell receptor signaling. And in diffuse large B-cell lymphoma in the ABC subtype, studies here done at NCI have shown that chronic active B-cell receptor signaling is an important driver of NF-kappa B. So we've known, and I'll just try to summarize this for you, but we've known for quite a long time that that ABC tumors, about 10% of them have a CARD11 mutation. But it's only in the last few years that we have understood this pathway upstream. And a few years ago, work done at NCI, led by Lou Stadt, identified that about 21% of patients with this ABC subtype had mutations in the B-cell receptor. And that's important because when you think of ways that we can target NF-kappa B and interfere with this pathway. So there's an enzyme called BTK, or Bruton's tyrosine kinase. And as you can see from this has a very critical role in mediating signaling to NF-kappa B in chronic active B-cell receptor signaling. And a few years ago, an inhibitor of BTK called ibrutinib was developed. This drug is very effective in other lymphomas and leukemias like mantle cell lymphoma and CLL. And it covalently binds to the BTK active site and is an irreversible inhibitor of BTK. And these are cell line studies showing that ibrutinib is toxic for ABC cell lines that have chronic active B-cell receptor signaling. And it's not toxic to the GCB cell lines, and it's not toxic to ABC cell lines that have a CARD11 mutation. We were involved then in doing a study of ibrutinib, again in patients with relapsed or refractory diffuse large B-cell lymphoma. And the hypothesis was that ibrutinib activity would be restricted to the ABC subtype, and that ibrutinib activity would be dependent on pathogenetic events within the B-cell receptor pathway. So this was a multi-center study. In total, 70 patients were accrued, and they all had relapsed or refractory diffuse large B-cell lymphoma. They received ibrutinib at a dose of 560 milligrams orally once a day until they had disease progression. And then at the end of the study, their outcome was analyzed by molecular subtype. So these are the patient characteristics in the study. These are the ABC patients. These are the GCB patients. In all of these studies, we always want to make sure that both populations are matched in terms of their clinical characteristics and their prior treatments in case there is, in this study, in case there's one arm that have better prognostic features, and for that reason they might do better. But as you can see here, when we looked at things like their ECOG performance status, their International Prognostic Index score, prior regimens, prior transplant, they were equally matched between the ABC and the GCB patients. So these were the results of the study. 23% of patients had a response, 14% of patients had a PR, and 9% of patients had a CR. But what was really interesting was that when we looked at response according to whether patients had ABC or GCB, almost all the responses were in the ABC subtype. Just one patient with GCB large cell had a response. So this really proved our hypothesis that adding ibrutinib or giving ibrutinib to these patients has selective activity in the ABC subtype. And these are the survival curves. Blue is ABC and orange is GCB. And as you can see, the median survival in the ABC subtype was 9.7 months compared to 3.3 months in the GCB subtype. One interesting evaluation that was done in this study was to look at mutational status and correlate that with outcome. And we looked at B-cell receptor mutations and MYD88 mutations and found that patients who had these mutations had a much higher response rate than patients who didn't. This is one patient on the treatment who, on the study, who had had 3 prior treatments and had been unresponsive to the most recent one. And this patient just received oral ibrutinib, and as you can see, after 3 weeks, they had a significant reduction in their disease. So as a result of the study that we were involved with, there is now an ongoing international study looking at patients with newly diagnosed large cell lymphoma who have the ABC subtype. And the question is, does adding ibrutinib improve the cure rate of these patients? So patients are randomized to receive the standard treatment R-CHOP with a placebo or R-CHOP with ibrutinib. And this is restricted to patients who have the non-GCB subtype. We don't do gene expression profiling to determine this, but we use an immunohistochemical algorithm called the Hans algorithm to decide if patients have GCB or ABC subtype. And this study has already accrued over 400 patients. The accrual goal is over 800 patients. So I think it will answer a very important question. Is adding ibrutinib helpful if you have the ABC subtype? So there are other mechanisms of NF-kappa B activation. We have a lot of interest in MYD88. About 30% of ABC lymphomas have got a MYD88 mutation. The Lymphoma and Leukemia Molecular Profiling Project, they surveyed a pathway called the toll-like receptor pathway and discovered in ABC lymphomas that about 30% of them had mutant MYD88. And this is an important mechanism of NF-kappa B activation. And there's a drug called lenalidomide, which is an immunomodulatory agent, and this has interesting activity in a broad range of hematological diseases. But it may be particularly helpful in the ABC subtype of large cell, where it works through IRF4 to increase interferon beta, which is toxic to tumor cells. And we're actually starting to do a study where we combine ibrutinib with lenalidomide and chemotherapy in patients with relapsed or refractory diffuse large B-cell lymphoma. As I said, there's a lot of interest in IRAK4, and now there are IRAK4 inhibitors in development. This just shows that IRAK4 inhibition is toxic to ABC cell lines. And in the lab, this is work that was done by Lou Stadt. And the IRAK4 inhibitor that he tested with ibrutinib is synergistic. So in talking about ABC lymphoma, I'm just going to talk a little bit about a study that we have just started doing. And there's a type of diffuse large B-cell lymphoma called primary CNS lymphoma. So these are large cell lymphomas that start in the central nervous system. And 95% of the time, they stay confined to the CNS. They don't go outside the CNS. And that's intriguing. They're not very well understood, but the question of whether or not there is an antigen in the brain that maintains them there and is responsible for them not going outside the brain in 95% of cases is a possibility. This type of lymphoma is increased in incidence in patients who have primary and acquired immunodeficiency. But interestingly, in immunodeficient patients, it's always EBV positive, and in immunocompetent patients, it's always EBV negative. It's been challenging to understand primary CNS lymphomas for a lot of different reasons. It's hard to do biopsies on the brain. The tissue in the brain can be challenging to interpret because its architecture is a lot different from other tissues. There are lots of normal brain cells that can make the diagnosis of certain lymphomas a little bit challenging. But although there haven't been a huge number of studies done, as the case is in systemic large cell lymphoma, but in the few that have been done, it appears that almost all primary CNS lymphomas are of the ABC subtype. And actually, the limited studies that have been done show that there are even a higher incidence of these various mutations in primary CNS lymphomas. So we're currently doing a study that incorporates ibrutinib with a chemotherapy regimen called TEDIOR in primary CNS lymphoma. I won't go into the details of the regimen, but I just really want to focus on the fact that when patients go in this study, they have 14 days of single-agent ibrutinib, and they don't have anything else. And we just recently, a few weeks ago, put our first patient on this study. And this was a patient who had had several lines of treatment before and had had radiation to her brain. And as you can see, this is the tumor in her brain before she started any ibrutinib. And after 3 weeks of single-agent ibrutinib, the area has almost completely resolved. This type of lymphoma is not lymphoma that does well with standard treatment. The outcome is not as good as systemic large cell lymphoma. And one of the challenges has been that it's very difficult to get certain drugs into the brain. They have to go through the blood-brain barrier. And a lot of the drugs that we use in primary CNS lymphoma are not the best drugs for treating lymphoma, but they're drugs that get into the CNS. And that's why we use them. And they're not that active. So this is really a significant response for a single agent like ibrutinib. And we just put our second patient on the study, and she also had a good response. And over the next 2 or 3 weeks, we have 3 or 4 more patients coming for this study. So next I'm going to switch a little bit to MYC-rearranged diffuse large B-cell lymphoma. I don't know how familiar you are with MYC. You probably know quite a lot about it, though, because it's a very common rearrangement. A MYC rearrangement is present in about 100% of Burkitt lymphomas and in about 10% of diffuse large B-cell lymphomas. This was something that was pretty recently recognized. And in large cell lymphoma, when or after standard treatment, the presence of a MYC rearrangement is associated with a worse outcome. So these people have a much, much worse outcome after or if they have a MYC rearrangement. These are 4 studies you can see the number of patients here and the treatment. Most patients receive CHOP or CHOP-like treatments. And in these various studies, up to 10% of patients, or up to 14% of patients had a MYC rearrangement. And in most of these studies, their outcome was much, much worse than you would see in patients who don't have a MYC rearrangement. This is one of those studies from the UK. There were 303 patients in this study. Most of them received R-CHOP. 14% of them had a MYC rearrangement. And as you can see, those with a MYC rearrangement had a much worse survival than those who didn't have a MYC rearrangement. There's been a lot of interest in our field recently looking at something called double-hit lymphomas. And double-hit large cell lymphomas have got 2 genetic abnormalities. And these typically have a MYC translocation, and they also have a BCL2 or 1418 translocation. And sometimes they can have a BCL6 translocation. But now various studies, and 2 large studies in the US have just been published, looking at over 150 patients with double-hit lymphomas. And they've shown that these people really have a bad outcome. with various different types of treatments. Some people in our field have suggested that they should have a bone marrow transplant up front in the initial setting, but really this has not shown to be beneficial in these retrospective studies that were published earlier this year. So as I said, we've had a lot of interest in developing an alternative regimen to CHOP called EPOCH. And one thing about EPOCH compared to CHOP is that it's as effective in tumors that have a high proliferation as tumors that have a low proliferation. And this is not the case in CHOP, where it's not very effective in tumors with a high proliferation. And because of that, we decided to test the regimen in Burkitt lymphoma. So a number of years ago, we started doing a study in newly diagnosed patients with Burkitt lymphoma. And our hypothesis was that because this treatment works very well in large cell lymphomas that have got a high proliferation, Burkitt lymphoma has a very high proliferation. It's close to 100% in almost all cases. So we hypothesized that this treatment would be very effective for patients with this disease. And we published our results last year, and we found that it was very effective. The time to progression was 97%, and the overall survival in HIV-negative patients was 100%. So this treatment works very well in Burkitt lymphoma. So then we went back and asked ourselves the question, does this work well in large cell lymphoma with a MYC rearrangement? So we looked back over all of our large cell lymphoma patients that we had treated in 2 studies, and we retrospectively assayed them for a MYC rearrangement. So we performed FISH on 108 cases, and we found that 8% of them had a MYC rearrangement. And this was equally distributed between different prognostic groups. These are low IPI and high IPI groups. And when we looked at the outcome of patients, we found that after dose-adjusted EPOCH-OR, patients who had a MYC rearrangement had an equivalent survival to those who didn't have a MYC rearrangement. And this is very different to what other people have found with standard treatments like R-CHOP. So we were doing a multi-center study of this regimen in Burkitt lymphoma. So we added a MYC rearranged arm. So we accrued patients with large cell lymphoma who had a MYC rearrangement, and they received dose-adjusted EPOCH-OR. And we just recently looked at the results of this study, and so far we've treated 52 patients. Their median age is 61. 71% of them are males. Most of them have a high IPI score. 86% of them had diffuse large B-cell lymphoma, and 14% had another similar lymphoma called B-cell lymphoma unclassifiable, with features in between diffuse large B-cell lymphoma and Burkitt lymphoma, and 45% of them were positive by FISH. Shown here is the progression-free survival of all patients. It's just under 80%. And the overall survival of all patients is shown here. And interestingly, when we looked at the patients with double-hit lymphoma, they, so far, and this is a very early analysis with limited follow-up, but our initial results show that this group of patients do well. And that's in contrast to the other groups who have published that they do not do well with any treatment. So this is an interesting finding. But as I've said, the follow-up is short. Our median follow-up is just about 14 months. So we have to wait for longer and continue with the analysis to confirm these results. Just briefly, there's a lot of interest in our field in large cell lymphomas that have high expression of MYC and BCL2, but do not have rearrangements. And these have been called double expressor lymphomas. And these make up a significant proportion of large cell cases, up to 44%. And they, in various studies now, have a poor outcome after R-CHOP or R-CHOP-like treatment. And there's a lot of debate in our field about how these patients should be treated. Several studies show that they have a poor outcome. One important point is that these cases usually track with the ABC subtype. And there have been many retrospective studies, but there are potential pitfalls of these studies in that immunohistochemistry, which defines these lymphomas, different labs have different cutoffs, different immunohistochemical methods are used, There's a lot of controversy about how BCL2 staining should be done, and different groups have done BCL2 staining differently. So for all these reasons, although the findings are interesting that double expressor lymphomas seem to have a worse outcome, I think that these results really need to be validated in a prognostic or in a prospective study that's very carefully controlled and that has just one or two pathology labs doing the immunohistochemistry analysis. And there are inhibitors of BCL2 and MYC in development, which may be interesting drugs for these types of lymphomas. So next I'm going to talk about targeting primary mediastinal B-cell lymphoma. And this is a type of diffuse large B-cell lymphoma, but it's really very different to the other subtypes, to the ABC or the GCB subtype, if you look at its gene expression profiling. And it actually much more closely resembles classical Hodgkin lymphoma. Classical Hodgkin lymphoma and primary mediastinal B-cell lymphoma share about a third of their genes. So they appear to be cousins of each other. And we're now understanding that there exists a spectrum of B-cell lymphomas that present in the mediastinum or in the chest. And at one end of that spectrum, you have classical Hodgkin lymphoma, or also called nodular sclerosing Hodgkin lymphoma. And at the other end of that spectrum, you have primary mediastinal B-cell lymphoma. And certain markers on the tumor cells help us distinguish these from each other, but PMBL has staining of CD20 and low staining of CD30, whereas NS Hodgkin lymphoma has strong staining of CD15 and strong staining of CD30. But we now know that there are lymphomas in between NS Hodgkin lymphoma and PMBL that do not fit into either of these boxes. And these lymphomas have been called mediastinal gray zone lymphomas. And they have histologic and immunohistochemical features that are in between NS Hodgkin's and PMBL. And there's a lot of interest in these. They're very rare. And we have been studying them at NCI over the last 20 years. So clinically, primary mediastinal B-cell lymphoma and classical Hodgkin lymphoma are also very similar. They both typically affect females in their 20s and 30s. They both have a similar presentation. 80% of people with classical Hodgkin lymphoma present with disease in their chest. And in primary mediastinal B-cell lymphoma, you almost always see disease in the chest. So both clinically and biologically, they're very similar diseases. And this is an old study, but it shows that the outcome of this disease has been favorable compared to the other subtypes. This study was done in the pre-rituximab era, so it's quite an old study, but it shows you that these people in the past have done well with standard treatments. But the treatment for mediastinal lymphoma is very controversial. And there's really a lack of prospective studies, and there are no randomized studies to guide people about how best to treat this type of lymphoma. And in the past, for the most part, primary mediastinal B-cell lymphoma has been approached like other diffuse large B-cell lymphomas. And R-CHOP has been the standard chemotherapy regimen used. And another thing about the treatment of this is that mediastinal radiation is typically given to patients. And the cure rate for progressive disease or recurrent disease with this lymphoma is very low. So it's really critical to optimize the upfront treatment approach, because if this disease comes back, most of the time it's incurable. And early studies in the field, these were mostly done by Italian groups about 30 years ago. They suggested that mediastinal radiation was a very necessary component of treatment. And they used a regimen called MACOP-B, and they did gallium scanning back then to look at residual activity after completion of treatment. And they found that about 66% of patients had a positive gallium scan after completion of chemotherapy. But then if they got mediastinal radiation, that went down to 19%. So studies like this made it a standard that oncologists gave mediastinal radiation to these patients. There's always been a suggestion from past studies that dose intensity is important in PMBL. It's important in Hodgkin lymphoma, and again, as they're very closely related, it's not surprising that it would be important in PMBL as well. But in terms of advancing the therapeutics of this disease, the fact that almost all standard treatments include mediastinal radiation is something that I think needs to be challenged, and we really need to find ways of removing the need for radiation because it has long-term problems. A very high percentage of people get secondary cancers. Females especially get breast cancer, and this group of patients live for a long period of time. So it's very important to focus on that when we're thinking about developing new treatments. So what have been the standard treatments for this type of lymphoma? Well, this is something called a MINT trial, which is the MabThera International Trial. They treated 824 patients with diffuse large B-cell lymphoma, and most of them received R-CHOP. And they did a subset analysis of patients with primary mediastinal B-cell lymphoma, and they identified 87 patients. So shown here are the outcome of those patients, their event-free survival and their overall survival. 70% of people received radiation treatment. Their event-free survival was 65%, and their overall survival was 83%. But what's very important in our field when we interpret this study is that they only included age-adjusted IPI scores of 0 to 1, which that does not represent the entire spectrum of this disease. And these are the patients who have the best outcome and the best prognosis. But if you look at all patients with the disease, this is a very interesting study that was published this year at Mass General. They looked back over their experience with primary mediastinal B-cell lymphoma. Patients received R-CHOP. They identified 63 patients, and 77% of them received radiation treatment. And their progression-free survival was 68%, and 79% was their overall survival. So kind of similar to what the other group got. But if you look at the outcome of patients who have a high IPI score of 2 or higher, you can see that these patients did really terribly. And patients who had advanced disease also did terribly following R-CHOP. So we studied dose-adjusted EPOCH-R in this population of patients because it's a disease of young people with a female predominance. There are good outcomes in certain low-risk patients following R-CHOP, but radiation is needed in most cases, and it increases the risk of secondary tumors and ischemic heart disease as people get older. And with R-CHOP, there are poor outcomes, as I've shown you, in advanced stage disease and patients who have a high IPI score. So there's a need to develop treatments that are as effective or more effective, but that remove the need for radiation treatment. So we studied dose-adjusted EPOCH-R with these goals in mind. This is the regimen shown here. 3 of the drugs are continuously infused over 4 days, and then the cyclophosphamide is given as a bolus, and rituximab is given on day 1. And this was the treatment paradigm for our study. Patients received 6 cycles of the regimen. At the end of treatment, they had a CT and a PET scan. And if their PET was negative, they went into follow-up. If their PET was positive, they had a biopsy to confirm that they had residual disease, and then they received radiation treatment. We had a number of patients with suspicious PET scans, and we typically follow those with another PET scan 4 to 6 weeks after the suspicious PET scan. And in most cases, that PET scan became negative or became less negative, and they went into standard follow-up. So these are the characteristics of our patients. We treated 51 patients. Most of them were females, and their other characteristics are shown here. But these are very similar to other studies of patients with primary mediastinal B-cell lymphoma. So we did not use radiation treatment, and at a median follow-up time of over 5 years, the event-free survival of our patients was 93%. So just 2 patients out of 52 required mediastinal radiation treatment, and 1 patient had surgical removal of a residual mass that contained some disease. But all the other patients did fine without radiation treatment, and shown here is the overall survival. I'm not going to talk too much about this, but one thing we learned from our study was that at the end of treatment, a PET scan is very helpful if it's negative. It has a very high negative predictive value. But if it's positive, and we found that half the cases were positive or mildly positive, it doesn't really tell you an awful lot. And what we did typically was follow these patients and repeat their PET in 4 to 6 weeks, and almost all of the time, the PET became negative. This was one patient on the study. At the end of treatment, she had an end of therapy PET, which showed this residual abnormality. And we observed her, and 6 weeks later, you can see that it's almost completely resolved. And the subsequent PET after this was completely negative. And as a result of our study, there are other studies ongoing in PMBL. The regimen is being tested in children. There's a German study that have so far treated 15 patients and have found the same results as us. There are pediatric studies in the Children's Oncology Group and Baylor groups that are ongoing. So we're looking forward to the results of these, and hopefully they will reproduce the same results that we had in our study. Just briefly, we did a study of patients with gray zone lymphoma, and they had a significantly inferior outcome in terms of their EFS and OS to those with primary mediastinal B-cell lymphoma. We're currently doing gene expression profiling of gray zone lymphoma. This hasn't been done before, and it looks like this type of lymphoma has its own unique molecular signature, and it has some aspects of the Hodgkin signature and some aspects of the primary mediastinal signature, particularly dendritic cell signatures, which are important in Hodgkin lymphoma, appear to be important in gray zone lymphoma, but also B-cell receptor signatures are important as they are in primary mediastinal B-cell lymphoma. So in conclusion, is there a better regimen than R-CHOP? This question is still unanswered, and we await the results of our randomized study where it's been compared to dose-adjusted EPOCH-OR. But it certainly appears that in subsets of large cell lymphoma, there are better approaches than R-CHOP. And I think in our field, we have to think of this now as constituting many distinct molecular diseases. It's not just one entity. And as we move forward and develop novel strategies, we need to keep this in mind and build strategies from new molecular insights into the disease. There's an increasing recognition that these subtypes need to be approached differently therapeutically. And we're starting to think of treating large cell lymphoma in terms of precision therapy. And for subtypes with high curability, such as primary mediastinal lymphoma, we need to focus on ways of reducing toxicity and eliminating radiation, which is really associated with devastating consequences down the line. So I'd like to thank all of my colleagues at NCI, and I'm very happy to take any questions for the next 5 or 10 minutes. Thank you. So, I mean, I guess it's a kind of a vague term, but I mean in terms of identifying targets and then developing treatments or directing treatments at a specific target. Because in our field, that's not been done in the past. Patients with lymphomas received chemotherapy treatments and regimens, which are very broad in terms of what they do. So they're not directed at one particular pathway. And, you know, that's why the side effects are pretty bad in terms of you really have to target everything, or everything is targeted. But now we have drugs like ibrutinib where it's, you know, targets one particular enzyme and is very effective. So, yeah. Yes? Right. So that's a very good question, and we're actually making a lot of progress in that. So, you know, I've been talking about conventional gene expression profiling, and that's very complicated. I mean, we can do it at NCI and in big centers, but it's not something that could be done in the community. But the group that I mentioned, the Lymphoma and Leukemia Molecular Profiling Project, they have developed now with nanostring technology a 20-gene predictor, which they just published recently. And this seems like something that could be, in the next few years, used in the community. But it has to be studied in clinical trials first. But it's pretty inexpensive and appears to be very reproducible. So it's looking very promising that we'll be able to use technology like that in the future. Yeah. Any more questions? Okay. All right. Thank you. Thanks.
Okay, our next speaker is Dr. Ravi Madan. He got his MD from the New Jersey Medical School in 2001. He then did an internal medical residency at Rutgers. And then in June 2004, he joined the NCI Medical Oncology branch. And he's now an assistant clinical investigator at the NCI. And he's the clinical director of the genitourinary malignancy branch. The title today is going to be prostate cancer. Ravi.
Okay, thank you all for coming. Okay. Great, thanks. All righty. Yeah, thank you all for coming. I don't know that I would have agreed to this as readily if I knew I had to follow Dr. Dunleavy, because he's a pretty good speaker, so I'm sure that was a good talk, but I'll try to do my best. It's also hard to encroach upon a meal, so I'll try to keep this on time. I do have a lot of slides. There's been about prostate cancer, although you don't always think about this in this way, or most people don't, it's a pretty dynamic field right now. There have been 5 new therapies approved in just the last 3 or 4 years, and there are 4 different modalities. So a lot has changed. What I'd like to do is actually provide you with enough information where it maybe gets you thinking about whatever lines of research you guys are doing. We'll try to get you through a lot of the background information and some of the scientific struggles we have at the very end, but I'd also like to get done with enough time that you guys can ask questions that are relevant to your own research, and we'll go from there. So we could skip through some of this. You'll basically figure out where we're going with this. Basically, we will talk about prostate cancer from soup to nuts, as they say, and maybe I'll just stay here. That'll be better with the pointer. Perfect. So as I mentioned, it's been an interesting few years for prostate cancer research, because a lot of things have been developed over the last couple decades and come to clinical fruition now. So this is a clinical course of prostate cancer. Essentially, these are patients where they start off with minimal tumor volume, and then they're usually asymptomatic at this point. The disease is non-metastatic, which means it hasn't left the prostate yet, and their disease is castration sensitive. So fundamental to prostate cancer is that the disease growth is fueled by androgens, namely testosterone. So depriving the tumor of testosterone is the primary focus of therapy. When limiting testosterone is enough to contain the disease, it's a phrase or state of disease we call castration sensitive. When the disease figures out mechanisms around that, we term it castration resistant. So that's just a part of the requisite vocabulary. So generally speaking, as you'll hear, the disease is curable with surgery or radiation, but unfortunately 20 to 40% of patients will have recurrent disease despite radiation and surgery. At that point, the PSA and tumor volumes start to rise. They're commonly treated with testosterone-lowering therapies, usually called chemical castration, and then there's second-line hormonal therapies. And as of 2010, docetaxel, which is a taxane-based chemotherapy, was the only form of treatment for metastatic disease that extended survival. Well, 2010, sorry, the radium popped up. That's a little bit later. That's foreshadowing, I guess. But in 2010, Sipuleucel T, or a therapeutic cancer vaccine, demonstrated its ability to improve survival in this population. Cabazitaxel, a second-line chemotherapy, also a taxane, also was approved in 2010. Followed by abiraterone and enzalutamide, 2 modern androgen receptor or anti-androgen therapies, which were developed in 2011 and 2012. These drugs have recently been approved in the pre-chemotherapy state for patients who haven't had docetaxel yet. And then that's And the most latest on this list was radium-223, which is a radiopharmaceutical, which is basically an infusional type of radiation. So as you can see, in just the last few years, there have been a lot of advances. Now, I think that what we need help from you and other researchers in the field is how to combine these therapies, how to use these optimally. And so hopefully, with the background I provide you today, you guys can go and figure out those tough questions and help out patients in the future. So this is a little bit older, a couple years older, but you'll see prostate cancer is diagnosed in about 250,000 men each year, and roughly about 30,000 die of the disease as well. So while it's something that patients can live with for a long time, it is still a lethal disease and very prevalent. You know, people always ask what are risk factors for prostate cancer. It affects 1 in 8 men, so it's not really clearly defined. There have been a lot of studies looking at genetic predisposition, but that's not clearly defined yet as well. There's always a suggestion that environmental aspects can play a role, or race. It's hard to say. Asians have far less incidence than Northern Europeans or North Americans, and for some reason the disease seems to be more aggressive in African Americans. In breast cancer, that aggressive nature in African Americans is sometimes socioeconomically related. In other words, they don't have the access to care, to screening. That's not the case in prostate cancer. So it does seem like there is differences within race as well, but a lot of this still needs to be fully defined. What about preventing cancer? We always talk about that, and I'm just going to spend one slide talking about a cautionary tale of prevention. So 5-alpha reductase inhibitors prevent androgen production within the prostate, which it was theorized to be a possible way to prevent prostate cancer in people with risk factors. 2 studies were done with 2 different agents, and both of them actually were positive. Both of them showed that there was about a 25% reduction in prostate cancer incidence. Now, these are standard FDA-approved therapies that are designed for people with BPH, so they're designed to shrink the prostate as well. So there was some confounding data that when patients were diagnosed after treatment with this, that they had more aggressive disease. It's thought that that's possibly related to the fact that because the prostate shrunk in size, if you stick a needle in there, you're more likely to hit cancer. That debate rages on a little bit. But nonetheless, despite this fact, there was never a reception of, wow, I can reduce my prostate cancer risk by 25% if I take these pills. The public did not want this treatment, largely because of the side effects from these therapies. And I'll show you later on some of the testosterone-lowering therapies. So it's interesting that we talk a lot about prevention and we want prevention, but when you actually get into the wild, so to speak, and you try to give a patient a therapy that has side effects for a disease they don't have, it's actually a lot harder to get the enthusiasm that you would think. So just something to keep in the back of your mind from the clinical perspective. Now, prostate cancer screening is also very controversial. I'm not going to go into any recommendations. As you know, they ebb and flow. But a rectal exam is one way to detect the prostate cancer. So here's the prostate. You have your scrotum here, your penis here, your bladder here, and the rectum here. So with a digital rectal exam, you can palpate the prostate. Now, as you can see, you can only palpate a very small portion of the prostate. This is a relatively primitive test. If there's tumor anteriorly or by the bladder, you're probably not going to feel it. And even if there's one here, who knows if you'll palpate it appropriately. So not exactly, as you can see, not exactly the most sensitive of tests. So along came PSA. Everybody wants a biomarker for cancer. Well, PSA is a biomarker, but it's not a surrogate. So, it's very controversial, the role that PSA has, because basically the end result here is we're diagnosing a lot more men with prostate cancer than may need therapy. So as you can see here, this is the actual prevention task force wording on PSA screening. There are actually there's a whole lecture in and of itself on the controversy of screening. Just realize that I think this slide probably says it all with prostate cancer screening. What happened in 1987? Well, it's not that everyone all of a sudden got prostate cancer. This is when PSA screening became readily available. All the patients below this baseline here got diagnosed, and that's why there's this giant peak. Now, this graph shows what some people comment on frequently, which is, well, if screening works, where's the drop-off in deaths? And I think you can kind of see in this line that it's starting to decline, and there are some perspectives that suggest that in the last the decade that followed this, that decline continued. But nonetheless, screening trials are still very controversial, or screening is very controversial. So I'll move on from that just just by saying controversial about 10 times. But now we'll get into a little bit more of the meat of the matter with prostate cancer. So one of the ways we look at prostate cancer under the microscope is with what we call Gleason scoring. So think of Gleason scoring as a pathological way to assess the aggressive nature of the disease. Or more practically, think of it as a way to assess its mobility. So what the pathologist will do is they'll look under the slide and look at the degree of anarchy, if you will. How disruptive is the architecture? How much do the cells look like the normal glandular material in the prostate, or how much are the kind of more anarchy-related mobile cancer cells? So if you get a 5 score, those cells are much likely, they're basically very disorganized and much more likely to metastasize. So that's where I bring up the mobility. So when you hear a patient diagnosed with prostate cancer, they'll get a Gleason 3+4. So what does that mean? Why can't we just add things up? We have calculators now. If your phone can do it, maybe. Well, the 3 represents the predominant pathology within the sample, and the 4 represents the secondary sample. So when you see a Gleason 3+4, that's exactly what that means. There is really no difference between a 3+4 and a 4+3. They both equal 7, so that's good. But really, if you have a 4, that's going to be driving the disease. Now, it's important in terms of determining their primary therapies, and I'll show you a slide on that shortly. Now, you can't really have any understanding of a disease without the staging. I'm not going to go into this in painful detail, but it's pretty simple, actually, with prostate cancer. If you just think of staging, surgical staging, if you have tumor in one lobe, it's 1. If you have tumor in 2 lobes of the prostate, each lobe's on kind of each side of the urethra, that's stage 2. If it's kind of broken through the capsule of the prostate, that's 3. And if it's metastasized, that's 4, and that's pretty generic for all cancer. So if you understand that, I think you can kind of get the gist of staging in prostate cancer. Oh, I didn't mention this either. If anything I says doesn't make any sense, I don't know what the format is here, but I'm happy if you just raise your hand and ask me, because I probably confused everybody if I've confused you. So feel free to ask questions throughout. So how do we figure out who needs to be treated with prostate cancer? This is the back end of the screening controversy. Does everyone have to be treated? The general rule is if you think a patient's going to live 10 years, then you should consider therapy. Now this will get into what we'll talk about shortly, which is prostate cancer is a disease you live with for years, and we don't have that luxury with most cancers. But if you have a patient who's 75 and has had their triple bypass surgery and a stroke, they're probably not going to live to 85, unfortunately. So maybe checking their PSA every year makes no sense, because maybe you don't have to diagnose their prostate cancer. Maybe that's something that's not going to kill them. And that's what it comes down to. This, it's what a concept called competing mortality, which is mortality or competing morbidities that lead to mortality, which is, are they going to die of other things? So if you have a 60-year-old guy who's had strokes and heart attacks and probably is going to live 5 years, then maybe he shouldn't get his PSA checked. And this is a primary doctor kind of conversation. But by the flip side, if you have a 75-year-old guy who's still hiking and walking around and good health, then maybe his PSA should be checked. So there's a little bit of a thought process that's necessary. So there's different approaches to prostate cancer once you diagnose patients. And one of those is called watchful waiting, which is kind of a nice way of saying really do nothing. So you diagnosed it in a guy who then you realize they maybe aren't going to live 10 years. And so you basically say, all right, we're not really going to pay attention to this. If you have symptoms, then we'll kind of address it. But we're just going to kind of take a hands-off approach. Active surveillance is actually a little bit different. This is where you're not sure if the patient needs treatment or not. They have a low-grade disease, so in that pathological aggressiveness, it's Gleason 6 or lower. And in those patients, they may not need treatment even if they're relatively healthy and young. So this is something where you check their PSAs, maybe you rebiopsy them every year. So that's the difference between watchful waiting and active surveillance. So this is confusing until you actually realize what it says, and then it's kind of interesting as long as you can work out literally the shades of gray here. So this is developed by Dr. Parton and his colleagues up in Johns Hopkins, and what they did was they took patients, these were older patients from the 90s, but I think it drives home the point of how Gleason score and age factors into our clinical management of patients. So these are the age, I guess, divisions. These are 50 to 50, 55 to 59, 60 to 64, 65 to 69, 70 to 74. And then here you see their Gleason score. You almost never see a Gleason 5 anymore. It's rare that pathologists grade anything less than a 6. But anyway, so the dark area here represents patients dying from their disease. The light area here represents patients, I'm sorry, the dark area is patients dying of disease. The light area is patients dying of other causes. So as you see, as you get higher up in the Gleason score, here's 7, here's 8 to 10. So 7's intermediate risk, 6 or lower is low risk. And you see why based on this. A lot more proportion are dying of their cancer as represented by the dark gray areas here. But, you know, if you have a Gleason 7 patient, which is intermediate risk, and they're diagnosed at 74, maybe, again, you have to assess their comorbidity. So this just kind of drives home that point, I think, pretty well if it's something that it's not too annoying to look at. So is surgery better than watchful waiting? Well, it sounds like a weird question, but in the 90s they asked this question. The data was published in 2000, and they said, yes, surgery is better than watchful waiting in patients with prostate cancer. Not too surprising. Very small study, but this is the data that really says that surgery is a therapeutic option for prostate cancer. What are complications from surgery? And this is important when we talk about what treatment patients should get. Incontinence, erectile dysfunction, infection, complications associated with anesthesia. This is relevant after, you know, Joan Rivers just died. You know that all procedures, even endoscopies, can be harmless. So you have to factor these things into account. Again, surgery is only relevant for patients with localized disease who have no evidence that the tumor spread beyond the prostate. Radiation is another option for patients with local disease. Now, I'm not a radiation oncologist. I won't I won't go into a lot of the details here, but basically, we're very good now at, better than we were before, at targeting the tumor with high levels of radiation to kill the cancer cells. And that's essentially the role of radiation. I think it's worth noting that there isn't randomized data that says should patients get surgery or radiation. Sometimes it's easy. Sometimes if they have, baseline characteristics that exclude them from surgery, like maybe they can't tolerate anesthesia, which is common in patients maybe over 70, then radiation is more commonly done. For patients who maybe have a history of colitis or inflamed bowels, inflammatory bowel disease, radiation can exacerbate that. So maybe then in those situations, surgery is better. But it's actually very difficult for patients because when they meet with their doctors, they want to know what to do. And the doctors kind of are like, well, you could do this or you could do that. It's kind of a personal preference. My perspective when I meet with patients is pick the treatment that has the side effect profile you're more comfortable living with. A lot of people just feel, I have cancer, I want to cut it out. That's a very common opinion too. So there's not clear data on, and that's basically also because people have made up their minds. So if they do a trial where you get randomized to surgery or radiation, people are like, well, I don't want radiation or I don't want surgery. So it's very hard for people to submit themselves to randomization like that. And that's why a lot of randomized trial efforts have failed in the 70s, 80s, and 90s. Brachytherapy is another form of radiation therapy where they inject radioactive seeds. Standard external beam radiation is delivered over the course of 6 weeks. Brachytherapy can be done in one surgical setting where they inject all these seeds, and the seeds emit low levels of radiation and kill the cancer. Again, this is better for low-risk disease or for patients with small prostates. If they have large prostates, then the radiation doesn't cover enough spectrum. So this is another form of radiation, which is an option in some patients. Complications with radiation, again, you can have erectile dysfunction. You can have irritation of the bowels and proctitis with rectal inflammation. There's a slight risk of secondary malignancies, sarcomas, and things like that. Supposedly, this has gotten a lot better with increased targeting over the last few decades with radiation, but it's still a risk you have to counsel patients on. So what about just giving hormonal therapy? I mentioned that, and I won't get into the molecular basis of this until later, but prostate cancer is primarily fueled by testosterone. Androgens produced within the body bind to an androgen receptor that triggers a proliferation cascade that leads to cellular growth and proliferation, rising PSA, growing tumors. So dropping testosterone levels will be an effective form of therapy. For men who maybe are too sick for radiation or surgery, but need palliation from their symptoms, primary androgen deprivation therapy is an option for patients. Again, it's something that is definitely very secondary to surgery or radiation. Surgery and radiation are potentially curative. Androgen deprivation therapy is not. That's another fundamental difference. So I'm going to cut through this a little bit quickly just because I want to get to more of the metastatic data, and then we can have some more discussion at the end. But what about combining these therapies? In other words, radiation with surgery, does that work? The answer is in some patients it does. What about surgery and androgen deprivation? There is data that in some patients it works. And what about radiation and androgen deprivation therapy? Again, in a subset of patients, there's data that supports this. So I'll share that with you right now. So in a study that looked at basically patients who had lymph node positive disease, so these patients had their prostate taken out. They also plucked out some lymph nodes, which isn't uncommon. It's called lymph node sampling. They do it in a lot of surgeries. And patients who basically had positive disease in their lymph nodes were given hormones. That's another way to say androgen deprivation therapy. And the other patients were not. And in this study, patients who got androgen deprivation therapy, or ADT as I'll call it, earlier lived longer. This data is very much skewed, though, because in this day and age with PSA, we don't wait like they did in this study, which was in order for the patients that got randomized to know ADT, they didn't get it until the disease had metastasized, which is much later than we'd wait for now. So the control group in this study was really not a relevant control in the modern era. But this data suggests that patients with a positive lymph node after surgery should start hormones. It's kind of a board-type question. In the real world, I think it gets finessed a little bit more, and I think that's appropriate. What about giving androgen deprivation? Oh, I'm sorry, I was a slide ahead of myself. This was just asking the question, could you give hormones to everybody before surgery? And the answer here was there was no big difference. But in node-positive disease, I'm sorry, I was one slide ahead of myself, there was clear data that it did better. But again, the control group for this isn't exactly a real-world control group now. What about giving radiation with surgery? So they found that basically in this study, if you had T3 disease, and you got radiation after surgery, you did better than if you did not. So if we go back to remember what the staging was, T3 or stage 3 disease was basically tumor that had broken out of the capsule of the prostate but hadn't extended widely. So it makes sense. They took these people who had prostatectomy, and if they had positive margins or evidence that the disease had broken through the capsule, they said, let's radiate them locally for a disease that may have been left behind. So it's actually not surprising that this is the population where the disease can benefit from radiation, as we call adjuvant, after surgery. It's important to note, though, that there have been other studies that looked at what if you had that positive lymph node and did radiation? Would they benefit from that? Those studies actually were negative. So I think what you can interpret there is if it's in a lymph node, it's probably in other lymph nodes throughout the body or other micrometastatic areas of disease. Androgen deprivation in those patients may make sense because it's a systemic therapy. Radiation is more focal. So what about radiation combined with hormone therapy or ADT? There's strong data that for patients with high-risk disease features, that's Gleason 8, 9, or 10, that 2 or 3 years of hormone therapy after radiation improves survival, and patients with intermediate risk disease, that's mostly measured as Gleason 7, even just 6 months of hormones may improve survival outcomes. So that's the standard approach there. If you have Gleason 6 disease and you get radiation in those settings, there's no data for hormone therapy. So that's just a sense of local therapy and kind of the different approaches and combinations. And so I think I'll move on to metastatic disease, but any questions about local therapy before I move on? Okay. So prostate cancer is relatively unique in that, as I mentioned earlier, there's a biomarker that allows you to detect disease recurrence before we have radiographic evidence of disease. It's relatively unique. Off the top of my head, I think, in terms of solid malignancies, I think they look at CEA a little bit in colon cancer and other GI malignancies, but it's not a hardcore one. CA-125 in ovarian cancer is another example, but nothing is used as routinely as PSA in prostate cancer. So there, it creates a unique situation for even 20 to 40% of men who get radiation or surgery, somewhere between there, unfortunately cannot be cured of their disease. And so they have basically what we call biochemical recurrence, so evidence of PSA rising after surgery or radiation. And so again, the therapy in these patients that's commonly used is to use androgen deprivation therapy because as I mentioned, that's the primary fuel source, in essence, for the cancer cells to grow. So the question is how to use that therapy. So there was a large study done in the 90s, and they presented this data just a couple of years ago, which looked at intermittent or continuous anti-androgen therapy or androgen deprivation therapy. So in other words, when you had a PSA immediately detectable, did you need androgen deprivation therapy for your whole life? Or could you do it intermittently, at least until there's evidence of metastatic disease? And so what they did was they randomized patients to intermittent, which was 8 months of androgen deprivation therapy, versus continuous. And as you can see, the long-term survival here is relatively equal beyond, about 11 years. This difference here wasn't significant. So the answer to this question is both are options. And I think I want to make a couple things clear. One is this is only an option for non-metastatic disease. When there's evidence, when there's radiographic evidence that we can see the disease on a bone scan or CT, and unfortunately all patients have to be on testosterone suppression therapy because otherwise the cancer can grow and you're a lot closer to having symptoms of your disease if you have metastatic disease already. But for patients with biochemical recurrence or this stage of disease, they may not require therapy for a few years. So in that situation, it's okay to alternate back and forth between a few doses of hormone therapy. And then what you do is you take a step back, watch the PSA rise slowly. As long as they don't have metastatic disease, then you can basically wait for their PSA to reach a certain threshold or a velocity, which is probably more appropriate, and then restart therapy. So that's essentially how practice is done. So does anybody get continuous therapy? That may be a question you would ask. The reason, and I'll go over the side effects of hormone shortly, they're not fun for patients because there are side effects. But why would patients want continuous hormone therapy? Well, some patients, I think you have to factor in that the side effects of anti-androgen therapy or hormone deprivation or androgen deprivation therapy, I'll go over with you shortly. But there is a side effect of not treating patients, and that's anxiety. So I tell patients, if you're up all night staring at the ceiling, wondering what your PSA is doing because you're not on therapy, then I think continuous therapy is appropriate. You're not going to have more side effects in the long term, but there are patients who prefer that. They just want that off their plate, not have to worry about it at least for a few years, and so that's how that goes. So again, if we look at biochemical recurrence and when it happens, I think this study actually gives you a sense of the longevity of these patients, the length of time for which these patients live with their cancer. So this was a study after surgery. On average, it took about 2 years for them to develop a rising PSA, 8 years for them to develop metastasis, 5 years to develop disease really that's consistent with death. This is one study, so these numbers vary a little bit. But again, this shows you why maybe continuous androgen deprivation therapy for this 8-year stretch may not be a requirement if the data supports it, which it does. This is older data without a lot of the newer therapies I'll talk to you about shortly, so it's hard to put this in complete context. The other thing is there are a lot of fancier, newer PET imaging strategies out there, so this diagnosis of metastasis may get moved up further, not because patients are getting more metastasis quicker, but more because we're using more high-tech scan technology. But this just gives you a sense of, this is the time frame you're looking at with prostate cancer. Very different, unfortunately, for patients with lung cancer and pancreatic cancer, where death and diagnosis can often occur within the same year. So metastatic prostate cancer, this is disease that's that's spread beyond the prostate. Only about 4% of patients have distant metastasis at diagnosis. This has a lot to do with screening. It'll be interesting to see if two things. One is more fancier imaging techniques come online, and two, as screening goes down, does this number go up? If you look in Europe or other parts of the world where PSA screening is not done, or even the US before 1987, this number is a lot higher. So, you wouldn't know you had prostate cancer until you had a painful bony metastasis. And I should also say that the development of metastasis in prostate cancer does not mean you have symptoms. It's often years after they get their first metastasis that they feel like they actually have pain symptoms from their disease, which is also a little different than other cancers. It's important to realize that distant metastatic disease in prostate cancer is not curable. Androgen deprivation therapy can drive PSA very low, sometimes to undetectable levels, but once it's left the prostate and really something we can see radiographically, it becomes very difficult in most cases to cure, and so generally you would consider it incurable. So then the aim of therapy really becomes a kind of maintaining quality of life, delaying death if possible, and decreasing the morbidity. So, okay, this is just something that comes up a little bit. I got a little confused by my own slide here. Sorry, hopefully it's not blurry up there. But what this is basically showing you is the sites of disease in prostate cancer. So 90% of men will have metastatic disease in the bones. 10% will have metastatic disease in other sites with no mets in the bones. This is data that shows something that I think is interesting, but part of which we already knew, which is patients with liver disease do worse than patients without liver disease. And this is from a big study done that showed that docetaxel was an effective therapy. So this is pretty mature data from over a decade ago. Not surprisingly, this is the Kaplan-Meier curve of patients with prostate cancer who had liver disease. Let me take a step back and I'm sure you guys know what Kaplan-Meier curves are. Oncologists, they love Kaplan-Meier curves. Is like what we do. So we have to show like these all throughout our talk. So just for patients who aren't as familiar, this basically represents all the patients or 100% survival. This is time. And over time, unfortunately, patients die. So that's what these curves represent. So the further to the right, the better. Again, these are a big deal for oncologists. Like EKGs are big for cardiologists. This is a big deal for oncologists, just in case someone out there is not as familiar. But basically, as you see here, patients with bone or lymph node and bone disease pretty much do about the same in kind of a midline thing. Interestingly, patients with lymph node only disease do much better. This is a little surprising because through the last decade or so that I've been treating prostate cancer, there was kind of this sense of, well, I never see prostate cancer in lymph node only, and the bone scan's negative, and so patients would refer them here because they're like, this person has really aggressive disease, because this represented a minority of patients. So the assumption was, I never see this must be bad, but this actually went along with what we had seen here, which is that's not necessarily the case. So it's very easy to fall into these dogmatic traps, even in clinical medicine with data. So it's just kind of another cautionary tale. But let's take a step back and talk about how we treat systemic prostate cancer, or I'm sorry, metastatic prostate cancer. And the primary way to treat that systemically is with ADT, or androgen deprivation therapy. This can be done in the olden days most effectively with orchiectomy. There are LH, RH, or GnRH agonists, which work by feedback inhibition. So basically, these tell the endocrine axis to produce more FSH and LH in the short term. It actually leads to a burst in testosterone production, but ultimately leads through feedback inhibition, through high levels of those secondary hormones, to tell the endocrine axis to stop producing FSH and LH, which are the testicular signals for testosterone production. So that's how agonists work. Antagonists work a little bit more conventionally in that basically they block those the pituitary axis. Degarelix is a newer version that does this. So these are different forms of anti-androgen therapy. There are older forms of anti-androgens, including flutamide, which isn't on this list for some reason, dilutamide and bicalutamide, and we'll talk about those shortly. So I think that I'll just skip through this slide real quick in the interest of time. So these are the side effects that I mentioned with anti-androgen therapy. This is the primary way to contain prostate cancer, but it comes with side effects. So when you decrease testosterone in males, not surprisingly, you get decreased libido and decreased erectile function. You get hot flashes as well. Decreased testosterone leads to peripheral conversion. Well, testosterone in the circulation is peripherally converted to estrogen. So the same mechanisms that lead to hot flashes in menopausal women lead to basically hot flashes in these men as well. Similarly, you get weight gain as well as decreased bone density. So kind of the same things that you see in menopause. You can see gynecomastia in some men. Fatigue is something that patients experience, as with all these side effects, really very variably. But it's not so much I don't want to get out of bed fatigue. It's more of like I walk 2 miles and I'm more tired at the end of those 2 miles than I used to be. So it's just important to have that in context there. You can see increased risks of diabetes. It's about 1 in 140 patients. Also increased risk of heart disease. So that's a little bit like it's a little bit higher likelihood or lower likelihood. It's about 1 in 300 patients. But these are things just to be aware of as we treat these patients. Realize that they still need therapy for their other metabolic conditions. So I kind of mentioned this before, but this is where a lot of the research and the new therapies have been approved recently. And this is the disease state that's metastatic castration-resistant prostate cancer. So metastatic, we all know, that means it's spread to the liver, lungs, bones. Again, in prostate cancer, it's usually the bones. But the castration-resistant part is worth discussing again, just to drive that point home. These are patients who you've already removed testosterone from their serum in their body. So in other words, their normal testosterone may be anywhere from 200 to 800, but with testosterone-lowering therapy, it's usually less than 20. I think for some of these trials, it can be less than 50. But unfortunately, despite that, the PSA is still going up, the disease is still growing. I'll discuss mechanisms of resistance later. It's actually a huge area, again, that maybe you guys can help with all your research. But it's important to understand when I talk about CRPC, or castration-resistant prostate cancer, this is the disease state I'm talking about. So different ways to basically limit testosterone from these patients when you've lowered the body's testosterone already is to come in with other therapies that target the androgen receptor directly. So if you lower the body's testosterone, the tumor may come up with other escape mechanisms, one of which can be increasing the number of receptors, which make it more sensitive to lower levels of testosterone. But if you come in with androgen receptor antagonists, these are older drugs, nilutamide, flutamide, bicalutamide, they can basically block through steric hindrance. They bind in the receptor site, prevent testosterone from getting in, and basically they don't lead to that chain reaction of cellular signaling that leads to cellular proliferation. Ketoconazole is an interesting drug. It was developed in the 70s and 80s as an antifungal, as the kind of name tells you. But it provided this weird nonspecific inhibition of CYP17, and there was thought that it decreased androgen production from the adrenal glands because the hormone shots that I mentioned earlier, the Lupron or Zoladex or GnRH agonist, decreased production from the testicles. So it was thought, well, these must produce less testosterone or limit testosterone production from the adrenal glands. So that must be why this drug works. But there was kind of variable acceptance of how it worked. With the newer therapies, these have more of a backseat role in metastatic disease, and are probably more limited to that to patients who are castrate resistant but not yet metastatic, where the newer therapies are yet to be approved. It's good to have a sense and actually, to be honest, the data of improving survival in metastatic disease with those agents is a little bit gray at best. So these are the therapies I showed earlier. There's docetaxel, a chemotherapy, along with cabazitaxel. In immunotherapy, this is the first and currently only therapeutic cancer vaccine approved. There's anti-androgen therapy, abiraterone, and enzalutamide. I'll go over the different mechanisms, and a radiopharmaceutical. So it's interesting because off the top of my head, I can't think of another tumor type that has this many variety of therapies available, especially over such a short time. So I think it's interesting. It shows how progressive this field is in prostate cancer. So docetaxel, as many of you know, is a chemotherapy that's developed from kind of this tree extract, bark extract. And the way this was thought to work for really many, many decades, at least in prostate cancer, I guess only 1 decade, since it was approved in 2004, was it was thought that by preventing microtubule assembly and disassembly, like taxanes do, this limited proliferation of the cancer cells, which requires mitosis, and therefore that's how it prevented cancer cells from growing. So that's all well and good, but we seem to forget what was discovered in like the 1940s for a long time in prostate cancer, and that is, I've said it like 10 times already, it's the androgen receptor and associated pathways that drive this disease. So not surprisingly, it's interesting that in recent years it's become a little more clear that docetaxel might be limiting prostate cancer cell growth, not because of the mitosis aspect, but more because the androgen receptor, once activated, requires microtubules to travel from the membrane into the nucleus. And by preventing that, translocation is actually how docetaxel is working. That also explains why the only 2 chemotherapies approved in prostate cancer based on survival are taxanes. It was really surprising when a second taxane was approved in patients who had already received 1 taxane. At the time, that didn't make a ton of sense. This is the study that was done that led to the approval of docetaxel in prostate cancer. It's really a 3-arm study looking at 2 schedules, every 3 weeks versus every week of docetaxel at different doses. This actually, even though it's given every week, was thought to have less side effects. Mitoxantrone and prednisone, it's important to note that this is the control arm. This is FDA approved in the early 90s for palliation, so decreased symptoms but didn't increase survival. What was commonly used even until recently, until we had more effective therapies, just for palliative benefits. So these are the results of the study. Again, here's your Kaplan-Meier curve. Oncologists love to show this stuff. So the green is docetaxel every 3 weeks. Docetaxel every week is the white, and the yellow is mitoxantrone. So this showed that in 2004 that docetaxel improved survival 18.9 months compared to 16.4 months, so a 2.5 months in survival. So this data was actually very momentous in prostate cancer because until then we had no way to improve survival beyond hormone therapy alone, and it actually drew a lot of attention. I've spoken to a lot of patient groups, and patients are like, 2.5 months. Chemotherapy is terrible. Why would I take this treatment for 2.5 months? What would somebody answer to that question? If anyone's listening. Is there any reason why the 2.5 months is misleading here? Because why would patients are like, well, and actually you can live with these side effects, and I'll come back with it. The dogma out there again is that chemotherapy is terrible. I don't need chemotherapy. If it's going to make me miserable for 10, 12 months when I take it, why should I take it if I'm only going to live 2 months? Any thoughts on this? So a couple of things. It's an average, so that's a very good point. So that's good. It's a median, so obviously for some of these patients, they're living much longer than 2.5 months. Any other thoughts? Okay, so you always have to look at the study design. So there's no placebo here. Patients got a chemotherapy agent. But big deal, right? I told you that one was approved for palliation. The other thing I didn't tell you, but you should always ask if you see studies like this where maybe the survivals are questionably short, is there crossover? And in this study there was. So when patients got their mitoxantrone and had progression of disease, there was crossover, and they were allowed to get docetaxel. So anytime, this is a kind of a fundamental thing, anytime there's a crossover in a clinical trial, it's likely that it underestimates the overall survival benefit. Usually when I tell the patients that, then their wife gets upset and hits them a little bit, and then they wind up getting chemotherapy because they didn't really understand the dynamics of it. But I think it's a good kind of, again, another generic lesson. And the expectation for survival of mitoxantrone and prednisone based on earlier studies was probably closer to 10 months. So I think, again, not everybody gets the benefit of crossover, but the 16.5 months here was certainly higher than expected. Do you have a question? That's a very good question. So that's always another good question to ask is when did they stop these therapies? So generally most studies follow consensus guidelines called RECIST. So this is basically a bunch of people got together in a room and created relatively arbitrary metrics of progression, and this is used universally for solid tumors. So for solid tumors, generally if your soft tissue disease got greater by 20% in size in basically the cumulative mass, then that's considered progression. In this study, one new bone lesion may have been considered progression. And back in 2004, probably a rise in PSA would have also been considered progression. So that's a very good point. I actually don't go into this in this talk, but I'll mention it now because you brought it up. PSA is a great marker for disease, but once they're metastatic, the number of lesions, the size of those lesions, that's the demarcation. So all the studies that are being done more recently are leaving patients on despite rising PSA and are waiting for progression on scans based on those metrics I've just described, so that way there's not premature discontinuation of therapies. So I think it is very important, and this is something that still, even though this is a consensus guideline that came out in 2008, 6 years later, this is something that's still not fully understood in the community, and that's progression in metastatic disease should only be measured by PSA. So it's something I think I'll add to this slide for next time. So there was also palliative benefits and quality of life benefits. I talked about the crossover and why that underestimates the survival benefit. So I think that's worth always kind of remembering for different trials. Now, don't get too scared by this slide. We have a lot of therapies in prostate cancer. We don't know how to use it, so I just thought it's practical to talk about some of the side effects, or at least show them. There's a lot of side effects with chemotherapy, with docetaxel, but it's actually something patients can tolerate very well. The biggest side effect of concern is neutropenia, which can lead to neutropenic infections and death. Other things like taste changes, fatigue are also limiting in quality of life, but I'm not going to go into this in too much detail. I just figure since we have so many options, it's important to factor in side effects when you're picking a therapy for these patients. So we shift to the next approved therapy in prostate cancer, which is a therapeutic cancer vaccine, Sipuleucel T or Provenge. There's a lot of political and dogmatic controversy around this agent, but if you don't know about that, I won't go into a lot of detail about it today. But basically, this is a immune-stimulating therapy that is generated from a patient's own peripheral blood immune cells. They're collected from the patient via leukapheresis, shipped to a central processing facility in Atlanta or Seattle, where they're exposed for 48 hours to prostatic acid phosphatase. This is the target antigen that the immune cells are being stimulated to target. After 48 hours, they're mailed back to the processing center where they're infused in the patient. A full course of therapy consists of 3 infusions, 1 every 2 weeks over a month. And it's when people are talking about immune checkpoint inhibitors now, this is actually the first really modern immunotherapy approved based on this study, which was called IMPACT, where they took patients who had mildly symptomatic disease and gave them the Sipuleucel T, the vaccine, or placebo, randomized them 2 to 1. And this was the end result. So the end result was that patients who received the vaccine lived 4.1 months longer than patients who did not. This is statistically significant and led to FDA approval. The controversy from this therapy comes from these overlapping curves here, which basically can also cause a little bit of confusion, because these therapies, like many immunotherapies, including some of the checkpoint inhibitors, such as ipilimumab and melanoma, they don't reduce your PSA, they don't make your tumor shrink, they don't basically do anything in the short term. Now, this is actually a lot of the focus of my research and my own personal clinical trials, but for the sake of staying on topic, I won't get into too much detail. But immunotherapy likely takes time to generate an immune response, and because it has an indirect effect on the cancer. It's not killing cancer cell directly like chemotherapy. We also think, based on retrospective data, that immunotherapies are better at slowing the growth of the tumor as opposed to shrinking it down immediately. And again, we're seeing this data actually with some of these checkpoint inhibitors, even though a lot of the data out there, they kind of show you the slide where one person's tumor shrunk away, but that's not really what's being seen with most patients. So a very different therapy. This caused a lot of controversy. I can talk about this at the end, but I have like 3 trials actually exploring this hypothesis that these therapies basically slow tumor growth over time. That's really beyond the focus, I think, of this talk, so I won't go into too much detail. But this is an FDA-approved therapy, so that's, I think, it's very well tolerated as well. Basically, infusion-like reactions. There was a small concern about strokes, but I don't think that's really borne out in clinical practice. I think if you think these therapies work, which I do, and you think it takes time for these to work, the earlier these patients can get them, the better. So that's Sipuleucel T. So abiraterone. Remember I mentioned ketoconazole before? It was kind of this weird antifungal drug that I wasn't around then, that people thought indirectly inhibited the CYP17 hormone in the adrenal glands and led to decreased testosterone because of that. And people used it, but there was a lot of controversy. Well, some smart people, I think in England, pulled this drug off the shelf and basically said, let's do a better version of ketoconazole. And they specifically targeted CYP17 lyase. It also hits hydroxylase as well, which leads to some of the side effects. But it's really the lyase component here that was really probably the more non-specific target of ketoconazole. And the reason why this is important is because it prevents androgen synthesis in the adrenal glands, like was kind of theorized with ketoconazole, the testicles as well. But as emerging data has come up in recent years for resistance, it also limits testosterone production within the prostate tumor itself. So remember earlier I said, like 5 times I think, testosterone is how this tumor grows. Well, we can limit the testicular production of testosterone, get patients at castrate levels, yet over time, there's still growth of the tumor. There's different mechanisms for resistance. I mentioned one is upregulation of the androgen receptor, maybe more of them. But another one, and this perhaps speaks to the sinister nature of cancer, the cancer cells themselves can produce their own androgens that almost in an autocrine fashion serve as their own fuel source. Again, it's really kind of creepy when you hear about it or think about it, but that's one of the mechanisms by which this cancer continues to grow. So abiraterone blocks these secondary forms of androgen production. So again, these were patients who basically took a drug from the 70s and 80s, and they got $1 billion drug on their hands, because I wouldn't be showing you this data if it was negative. But this was the trial, the phase 3 trial in patients who had already had chemotherapy. This was the result of that trial. Patients, so you can't compare the length of survival, because these are patients that are much more further along than either of the two studies I showed you before. And also, they're done at different time frames, so it's a little hard to compare. But these are, the placebo arm, I think, is a relevant comparison, where there was a significant improvement in survival of patients who got abiraterone, and this led to FDA approval of this drug. There has since been, this was done in patients who had already had chemotherapy. This study has since been done in patients who were chemotherapy naive, so had much longer time frames to live. The survival there was on average, about 25 months. And so it's also approved for patients who haven't had chemotherapy. So now effectively it's approved for all patients with metastatic castration-resistant disease. This is just looking at some of the progression data versus placebo. And I think in the interest of time, we'll move on. But you can see that most patients have even a decline in their PSA, more so than the placebo. Side effects, again, don't get too caught up on it. The big side effects with this therapy, unlike chemotherapy, is really edema or lower extremity edema. You can see this with docetaxel, but this is something that it's very strange, because it happens in some patients to a large degree, in other patients not at all. So we haven't really figured out. This is probably actually because of the nonspecific lyase, CYP17 lyase inhibition. Targeting just the hydroxylase, or targeting just the lyase, would probably be good to limit the side effects, but the hydroxylase inhibition actually leads to some increase in other hormones, which leads to the edema. There are newer agents. We have a trial actually now with the treatments just targeting the lyase. But these are the side effects. Overall, it's a well-tolerated drug. So when you see this list of side effects, just in general, another kind of thing for you to understand, remember that anytime a patient's on a trial, they walk into their doctor's office, we ask what's wrong, it gets captured, then it winds up as one of these percentages. That's why things like constipation and diarrhea are in everything, because if you follow enough patients over time, they're going to have that. So even the placebo arm has some of this stuff. You have to look and kind of make the comparisons. So cabazitaxel is the second-line chemotherapy that's approved for prostate cancer that I mentioned. This is interesting because it differs from, it's a taxane that's synthetic. It differs from docetaxel just by the alteration of a couple of these side chain groups. Cynically, you may say that the company developed this because docetaxel goes off patent in about 2 years, and they were hoping that maybe they can get lucky with another taxane that does the same thing that'll have a longer patent life. I think we'd all like to hope that that wasn't necessarily the case. But regardless, it is surprising that a second taxane worked to extend survival in patients who had already progressed on a previous taxane. Again, I think this speaks to the underlying impact of the taxanes preventing androgen receptor translocation, and that being its true mechanism of action. So here's a randomized trial in patients who had already had docetaxel and progression on it. Again, you see that the control arm in this was mitoxantrone and prednisone. This led to improved progression, double the progression. This is from 3 months, from 1.5 months. You're talking about short time frames in these patients with very advanced disease. But survival was 15 months versus a little under 13 months. And again, this was statistically significant. The side effect profile here was striking in that there were 5% of patients who had, at least based on the original reports, infection-related deaths on this study. And that's actually a considerably high amount. With the advent of newer therapies, this is kind of much less thought of as a great option for patients. You know, in that study, which was done largely outside the United States, growth factor support, which can get white counts up quicker, probably would have minimized those deaths. And so that's how it's commonly used in clinical practice in America. But because of those treatment-related deaths, it did caution some of the benefit of this and also the subsequent approval of abiraterone and a couple other therapies. But remember, this factors all into the clinical synthesis of seeing these patients and trying to pick out which therapy to use. So enzalutamide. So again, enzalutamide, like abiraterone, they took old drugs. These were the old androgen receptor antagonists like that I had mentioned earlier that were approved in the 80s, developed in the 80s, like bicalutamide, nilutamide, and flutamide. Again, this is a modern version of it. So Charles Sawyer and his group developed a better version, a better mousetrap, if you will. It binds to the androgen receptor. These are comparisons to bicalutamide, the older drug, and you see that it has better binding affinity to the androgen receptor, and unlike the other agents, it has better impact on preventing the androgen receptor from traveling to the nucleus, thereby basically sending that growth signal. So better version with really better clinical outcomes. That was, again, a study here with docetaxel, treated patients who had progression, randomized 2-to-1 in favor of enzalutamide. About 1,200 patients in this study, a large improvement in survival, 18.4 months versus 13.6 months. Time to progression was significantly improved. This drug was approved a little over 2 years ago for patients with, again, metastatic disease who already had chemotherapy. I'm sorry, I just interjected this slide because based on this data in patients who had not had chemotherapy, and you saw an improvement in survival here, basically the median survival actually is all the way out. I think it was like 33 months versus 31 months, but you can see the separation in the curves starts off here and is pretty profound. This was, again, significant statistically and led to approval of this drug in patients who had not already had chemotherapy. So these were kind of distinct disease states. And so now, like abiraterone before it, all patients who have metastatic castration-resistant disease are eligible for enzalutamide based on randomized controlled data. This drug is actually very well tolerated. In giving it to patients, there is some fatigue, but that's actually makes this probably the premier choice, in my opinion, for patients with metastatic castration-resistant prostate cancer, because this is the one that's going to impact their quality of life the least. Very profound effects, very well tolerated, and that certainly factors into my thought process in giving this drug. So alpha-radin brings us to our final class of therapeutics in prostate cancer. It's similar to older drugs, like or older radiopharmaceuticals like samarium and strontium, except that in that it basically is a radiopharmaceutical agent that circulates through the body and delivers basically radio energy to the tumor microenvironment. The difference with alpha-radin, though, it's based on an alpha particle and not beta particles. The difference there is that alpha particles have a shorter radius which they basically fire off from their parent particle. This means that they're more likely to hit the tumor and less likely to hit bone marrow cells, because that's often where the disease is. And prostate cancer basically is in the bone, near the bone marrow, where if you have far-shooting radioactive particles, you're going to drop your platelets and your blood counts, and that often significantly limits the ability to give these agents. The older versions of these agents that I mentioned were FDA approved for palliation because it did improve symptoms in patients but did not improve survival. So this was developed with hopes that it could improve survival. And based on this randomized study in patients this was a mixed population of patients who had chemotherapy and those who had not. And so this actually also improved survival. These were probably symptomatic patients. That's why the survival times are a little bit shorter than some of the other pre-chemotherapy states. But you see the survival time is roughly 15 months versus 11 months. And again, this led to FDA approval. So people aren't really clear on how to use this. I think it's probably still reserved for patients with symptomatic bone disease. But I think that's one of the things that we have to figure out is how to use all these therapies. Pretty well tolerated in general. So it's a good agent. There is some myelosuppression. As you can see there, anemia, you do see lymphopenia, leukopenia, thrombocytopenia, but not to the degree at which we saw with the older radiopharmaceuticals. So this is just kind of that summary of where we are now with all the therapies in prostate cancer. So a lot of options for men with prostate cancer, but we don't know the sequence or what combinations may work better. And that's something that, again, we need some basic science data on, clinical data on. A lot of trials are ongoing. How would I treat a man with prostate cancer just in general? The way we follow patients, we often find that they have metastatic disease after their recurrence and follow them with just PSA rising. Once they have a small area of metastatic disease, then they become eligible for really all these therapies. And in my ideal worldview, this is again my opinion, not based on randomized data, we think vaccines work, but we think they work earlier. So I would start off with a dose of Sipuleucel T, but we know it doesn't change short-term progression, so I wouldn't wait for progression. I would probably move on to another therapy. The next therapy there, I think that makes the most sense from an efficacy standpoint, but also a tolerability standpoint, is enzalutamide. Again, the AR blocker that's well tolerated. And then once there's progression there, it becomes a little unclear. I'll go over some of the cross-resistance data with abiraterone, but since they're all targeting the androgen pathway, once you use one effective therapy, the other therapies are less effective. This is something we're dealing with. So I think radium-223 is good for patients with symptomatic bone disease. I think rapidly progressing disease, chemotherapy has a role. So, which kind of brings me to my next couple slides. You may think chemotherapy is on the outs because it's not as well tolerated, and most people felt that way too. They thought we have abiraterone and enzalutamide. In a few years, we'll have son of abiraterone and son of enzalutamide, which are better drugs. But then they had already started to do a study where they took a small population of patients, about 5 to 10% of patients, maybe a little bit more. These are men who have diagnosis of metastatic prostate cancer, but a normal testosterone. So either they're flat out newly diagnosed with metastatic disease, or they, after surgery or radiation, they showed up at their doctor's office a few years later, and they have a normal testosterone and metastatic disease. So this is different than patients who have a PSA or biochemical recurrence and are conventionally treated with androgen deprivation therapy, where by the time those patients get metastatic disease, they're already castration resistant. These patients are castration sensitive. And so this is interesting, right? So it's a very small percentage, about 5 to 10% of patients. But this is interesting because, and remember, this is very early on in that disease course that I talked about. Patients who got hormones with docetaxel at that very early stage of disease, again, small percentage of patients, lived 13 months longer than patients who did not. This is a remarkable finding. We don't see this in cancer very much. You've been seeing all the 4 and 5 months I've been telling you about and been pretty excited about earlier. This, again, has to do with the fact that you're talking about 6-year readout here. So if you start and show benefit in the early going, you can show these benefits over the long term. But this is relatively new data from just this past year at ASCO. And so it was really only the patients with high volume disease. And so these were patients with lesions in their liver, which I told you were poor prognosis, or patients who had multiple bone lesions, including one outside of the normal distribution of the disease, so outside of the spine and pelvis. So if they had 4 lesions with one outside that area, they were considered high volume, and those were really the patients. Other patients who had maybe one random bone lesion, there's no evidence yet that the 6 cycles of chemotherapy given to these patients was a benefit. But I think this is a reminder that chemotherapy still has a very important role despite some of these newer agents. So I think we have a few minutes to really talk about future directions, and maybe this can impact some of your research. I've kind of alluded to mechanisms of resistance. I've kind of already talked about how we have ongoing trials trying to figure out sequence. I'll come back to that in a moment, but in multiple modality therapy. But understanding mechanisms of resistance is important. So this is one review of the literature that we did recently that looked at patients who got chemotherapy after abiraterone. So remember, abiraterone targets that CYP17 liase that prevents secondary androgen production. Docetaxel is a taxane. We think it works through translocation of the androgen receptor, and this data really supports that because I showed you that previously docetaxel had, basically about a time to progression benefit of about 10 months and survival benefit of about 18 months. But if they already got abiraterone, there is much less response. Time to progression is about 4 months, and then survival is about a year. So this, I think, speaks a little bit to the fact that these patients are more likely or less likely to respond as well to docetaxel because of the underlying mechanisms of cross-resistance. Interestingly, we have a clinical trial that's combining docetaxel with another agent, and Dr. Dehatter is our PI on that study, and we've seen remarkable delays in time to progression. This is kind of one of the clinical things that needs to be done. How can you improve other therapies by adding to it to really limit these cross-resistance? And so that's something we're looking into. This is with an agent called cabazitaxel. I'm sorry, not cabazitaxel, cabozantinib, which is a TKI inhibitor targeting c-Met and VEGFR2. So we'll look into some more data with that in the future. But this slide, I think it's in your packet, which is good because I won't go through it in excruciating detail as we near the end. But it highlights the mechanisms of resistance to docetaxel in prostate cancer. I think we talked about there can be pumps that basically increase pumping of the docetaxel outside of the cancer cell. There can be mutations in the pathway or mutations in the angiogenesis pathways, mutations in the microtubule binding site of docetaxel. So these are mechanisms of resistance to docetaxel. I think this slide's a little more interesting because it shows the different mechanisms of androgen receptor resistance. Again, we think docetaxel is really targeting the androgen receptor. So, secondary production of androgens is very important. That can be from the adrenal glands, and that's what abiraterone targets, as well as from the tumor itself. So this isn't going to be detectable in systemic circulation, but it might be relevant in the tumor microenvironment. So this is an important part that we have to look into. How can we limit secondary production of androgens by the tumor and beyond abiraterone? So there's lots of options looking at that. The androgen receptor itself may change in important ways. There can be more of them, which makes perhaps the tumor more sensitive to lower levels of testosterone. But I think one of the other ways in which the androgen receptor changes, or the androgen receptor pathway changes, is that it loses its receptor. So in other words, you basically have a constitutively active androgen receptor, essentially, because no longer does it require that binding site for activation. So in other words, and there's been a lot of data. There was a New England Journal article just a couple weeks ago documenting a splice variant. That's what these kind of modified androgen receptors are called. This is particularly androgen receptor splice variant 7. And basically, it doesn't have a binding domain. So if you don't have a binding domain, you can't block it, and it leads to a constitutively active pathway. So this is the understanding that's come about with new and improved therapies. And so we have to figure out, perhaps with your help in the future, how better to sequence and combine these therapies to overcome these resistant pathways and how to develop new therapies. I think there's a lot of opportunities with immunotherapy, as we already saw, Sipuleucel T has done this in prostate cancer where it's improved survival. That most certainly is not targeting just the androgen receptor pathway. It's likely targeting the immune system, which is enhancing cell killing. So perhaps immunologic stimulation with other therapies is one way to do that. That's, again, a focus of my research and my colleagues here at the NCI and some of our lab people from the LTIB who are with us here today. The other thing is that some standard therapies can combine well with immunologic therapies, and that's something we're also looking at. So a lot of progress in the last 5 years. That's probably the byproduct of a lot of basic science research in the decades before. But with progress now comes new problems and new questions, and we need to get the answers to those. So I think the other thing that we have to ask ourselves, can we move some of these new therapies? I remember I said they're all approved in metastatic castration-resistant prostate cancer. Can we move them to the adjuvant setting and actually improve cure rates? So can we do hormone therapy with enzalutamide, very well-tolerated anti-androgen therapy? Can we give 6 months of that before surgery and shrink the tumor down so much that we can cut it all out? Or somehow combine it with radiation? What about immunotherapy in those situations? Maybe an immunotherapy can stimulate the immune system to mop up microscopic areas that are left behind by surgery or radiation. These are active areas of research. And I think you may look at some of these increments and say, well, 3 months here, 4 months there, big deal. But as that last study with chemotherapy showed, if you move this earlier in the disease process, your pivot point becomes greater and your clinical impact could be profound. And I do think that some of these therapies, perhaps combined in a neoadjuvant or adjuvant setting, can potentially increase the cure rate in prostate cancer. And that's really should be our focus here. So hopefully I left a little bit of time for questions. I'm happy to stay a few minutes after. I apologize for taking the full time, but please let me know if you have any questions. Right. So it's important to clarify this population. So remember, most men in this country who don't get cured by surgery or radiation have a rising PSA and are put on hormone therapy before they're metastatic. So then when they finally develop metastatic disease, they're de facto castration resistant. This is a small subset of patients, roughly 5 to 10%, maybe a little bit more, but a small subset of patients who are diagnosed with metastatic disease before we either knew they had prostate cancer or knew they had recurrent prostate cancer, and therefore they weren't on any hormonal therapy. So I think this highlights, again, potentially the impact of docetaxel on the androgen receptor in patients who were basically naive to androgen deprivation therapy in the past. I'm a little concerned that as this data gets translated into the community, people are just like, oh, I should just give docetaxel right away to everybody. That's not what this data says. And I've had some people actually talk to me about that. And it's an important but nuance to this. But so I'm glad you asked. Yes? Mm-hmm. So you know, it's interesting, but there were studies done before docetaxel, and they were negative. So it's right. It doesn't in mouse models. It does improve some mouse models, you know, but clinical trials did not bear out benefits. So perhaps there's something about the way these taxanes bind to the microtubules that are more relevant in androgen receptor translocation. And I think it is very interesting that those are the only two, you know, that they're two relatively similar taxanes. Remember, they only alter the hydroxyl group a little bit. That's a good question. Yes? Yeah. Yeah, so there have been neoadjuvant studies done with Sipuleucel T. I actually have, with my colleagues at the down at the clinical center, I have clinical trials in patients who are newly diagnosed being treated with radiation, patients with rising PSA, patients who have non-metastatic disease. So we all agree that moving it up earlier is, I have a lot of those studies with my colleagues, but so do a lot of other people. The issue is, and brings up a good point, why were all these studies done here when I told you the most benefit is here? From a pharmaceutical development and ultimate path to the clinic or path to market, this is where your clinical endpoint becomes the quickest. So that's where you get your answer the quickest, and therefore your financial windfall. Now, it's not surprising that abiraterone and enzalutamide showed their approval here before here. Now, some of that's time because of accrual and things, but you know, if these studies were negative, these studies might have been shut down, and we've seen that with other things. So well, the company's probably in financial trouble. So it's interesting because, as I mentioned, there's a lot of political backlash for Sipuleucel T. A lot of things were done complicatedly with them and by them. But, you know, no one seems to be complaining about Avastin, which improves survival by a couple months in lung cancer, but costs just as much. This new PD-L1 inhibitor in melanoma is going to hit market at about 150 grand, as opposed to the 93 grand for Sipuleucel T. Cost is a relevant concern for all new therapies. Enzalutamide costs roughly about $8,000 a month. So their clinical trial in non-metastatic disease, they quote the median time to progression of about 16 months. It's a lot of math for me. I think the median was probably somewhere between 10 or 12. Makes the math easier. That works out to about $80,000 to $96,000. Cost is a relevant issue throughout. Sipuleucel T got a lot of backlash because people were like, well, you're not even making my PSA go down. Why am I paying $93,000? Hopefully some of that's gone away. I think now everyone's kind of on the immunotherapy bandwagon a little bit, but cost is relevant for all these therapies, not just on my screen. I'm sure the things Dr. Dunleavy thought about. That's a whole different problem, and I'm not smart enough to address that. But these are things we are going to have to address. So it is a good question. I didn't show this, but studies have been done looking at radiation with docetaxel and surgery with docetaxel in the newly diagnosed setting, and those studies did not show long-term survival benefit. They didn't show biochemical recurrence benefit either. Some of those studies are still being redone or done differently, but to date, those studies have been negative. It's a very good thought, though, wiping up microscopically what's left behind.
Thank you so much. Go ahead.
Yes, any other questions, I'm happy to answer them. Thank you for staying. Sorry to interrupt your dinner.